Thank you. Uh, Go on to the next presenter.
Another clicker, please.
Jamal Miller.
Great. Good afternoon to Chairman Senator Hernandez, as well as to Assembly Member Bonta. I appreciate this opportunity to share on behalf of California Department of Public Health's Office of Health Equity. Excuse my back to those who are behind me, but I wanted to have at least this perspective to share today's presentation with you. I call this slide the stair steps, and unfortunately these aren't the stair steps to heaven, if you will. When you look at the disparity between African Americans and Asian Americans, 86.1 in life expectancy, and African Americans 73.3, I often expound upon this need to really disaggregate once again, and I'm glad that those who have spoken prior to me have highlighted really the need to disaggregate that Asian American component. And oftentimes what we found out of the Office of Health Equity and within the California Department of Public Health is when we look at the array of data resources to pull together numbers like this, there's a lack of standardization. So we share that interest in having a more standardized approach across the array of data sets out there so we can report in a more accurate way about disparities and inequities here in California. The highlight on this slide is particularly at the bottom, however, that an Asian American baby born today in California is expected to outlive an African American baby born the same day by more than 11 years. And our objective, within one of the objectives that we have in the Office of Health Equity, is we literally want to get flat. We want to flatten maps and data like this so that we can show how our state is moving forward to achieve health equity. An important part of the data discussion that often lacks is the economic implication of health inequalities across our country, and particularly within the state of California. This study that I cite today, commissioned by the Joint Center for Political and Economic Studies, highlights between the years of 2003 and 2006 that the combined costs of health inequalities and premature death were $1.24 trillion. That's direct and indirect costs. But when you look specifically at the opportunity associated with eliminating health disparities for minorities, that would have reduced during that same period of time direct medical care expenditures by approximately $230 billion. And if you give or take a few million or even $1 billion here, this number and these numbers are still fairly high, and it just shows us the economic implications of premature death. And I think it's really important that we take in the economic implications and the growth model implications of why achieving health equity is advantageous for the state of California. We've talked earlier about income security as a key social determinant of health. In the next two slides, I want to highlight what this looks like, because when we look at the demographic comparison and see the uneven distribution of household wealth across racial and ethnic groups in California, we see that demographically there is a huge difference when we compare those households and the wealth that they are responsible for. So if we highlight African Americans in their households represent 6% of California households, but hold about 2% of household wealth. And particularly within our culture in America, having income security plays a key role in your ability to access the resources and the amenities that are associated with having a higher quality of life, and as a byproduct, an increased life expectancy. And to expound further on the role of income security, we often have talked about changing institutions and systems by addressing social determinants of health and going upstream in our systems and institutions. But I would contend that we also need to go upstream in the life course and look at how economic disparities impact our infants, our babies, even prior to when they're born. And this study that I highlight today, according to research coming out of the University of Colorado at Denver, women who are poor experience higher cortisol levels in pregnancy and give birth to infants with elevated levels of stress, of the stress hormone. And we all know that this heightens the risk of developing serious disease later in life. If we look specifically around the epigenetic dynamic here, the study, and it was published in the American Journal of Human Biology, is that this is the first study that measures cortisol level in infants and relates it directly to the socioeconomic status of the mothers during pregnancy. And this is really, really important when we think about the broader determinants of equity or the social determinants of health, that beyond just the doctor and the hospital, it's very critical that we have care and coverage, but even beyond that, there's this 90% dynamic inclusive of income security that's playing out in the lives of our babies even before they're born. And having a nurturing environment for our children and for our mothers is key to addressing this issue. So addressing the broader social determinants of health is key if we want to transform the conditions in which people are born, grow, live, work, and age. And uniquely, each of these social determinants that we have listed here, it intersects uniquely. If we're going to have healthy people, if we're going to have healthy communities that come from healthy environments that come from healthy societies, we have to seriously consider from a budgetary standpoint, from a policy-making standpoint, how we each respectively across all the branches have a role and responsibility to affect the social determinants of health and how they intersect with people, communities, environments, and healthy society. For the sake of time, I'm going to skip this slide in particular. I come today kind of partially with a solution. It's not the ultimate, solution to the problem that we're talking about, because there are so many dependencies that we have across private and public sector to achieve the challenges we have in data. But I'm glad to highlight today our Healthy Community Data Indicator Project, which is affiliated with the Health and All Policies Task Force. And I have the honor of leading a team that staffs the Health and All Policies Task Force, and it's affiliated with the Strategic Growth Council. A part of that work that got underway about 3 to 4 years ago, more than 4 years ago, was an assessment and evaluation with local health departments as well as with the 22 task force members for health and all policies. And the question was literally asked, what makes a healthy community? And when we think about the data and the information that's needed to define how we can meet the basic needs for all, how we can have a community or society that addresses quality and sustainability, a society that addresses health and social equity, a society that addresses social relationships that are supportive and respectful, and then adequate levels of economic and social development. Understanding that these are highlights of what make a healthy community, but understanding that there is a lack, based on the feedback that we received a few years ago, there's a lack of a cohesive data resource to provide that information, particularly to local health departments around planning efforts. So in response to those findings, the Healthy Community Data and Indicator Project was initiated, and we have the privilege of having that team work out of the Office of Health Equity within the California Department of Public Health. And the intent of this project is to enhance public health by providing data, a standardized set of statistical measures and tools that a broad array of sectors can use for planning healthy communities and evaluating the impact of plans, projects, policy, and environmental changes on communities across the state. And we're proud to say that many local communities, both from a private and from a public perspective, they've used many of the indicators that have come out of our Healthy Community Data and Indicator Project to do community health needs assessment, to make general plan updates. And even though this project is not complete, we'll ultimately have 60 indicators when it's done. We have well over 20 completed now. It's already been shown to be of great value at a state level as well as at the local community level. The difference in this data resource is that it focuses particularly on two areas: health and the factors that influence health in the built and natural and social environments, and then health and social equity. So we're looking through a health and a health equity lens and creating this Healthy Data Community and Indicator Project. As I stated before, we have just under actually 60 indicators broken out by those areas of interest as to what defines and makes up a healthy community. And to give you some graphic examples, here's one highlight from our Healthy Community Indicator how-to manual, which we produced towards the end of last year. And this gives you a place-based example, particularly in Alameda County. And we see a white child from the Oakland Hills can expect to live 85 years, whereas an African-American child living in West Oakland, just a few miles away in close proximity, can expect to live only 70 years. And each of the bullet points that you see with regard to a child from West Oakland and then as an adult, each of those bullet points is data or information that's come out of our Healthy Community Data and Indicator Project, publicly available. And even though it's not fully completed, we're glad that we have this resource to be able to share with all. And we have, consistent with the theme today, run into some barriers and challenges when we look across the array of data resources that we pulled from and that we've synthesized. So we share, once again, that commitment to try and find a way with respect to standardization and disaggregation. Some quick examples I want to share, ways in which the Healthy Community Data and Indicator Project shares information. So from a county perspective, on the left-hand side, we see the average cost of a market basket of food, of nutrition. The hot spots in particular, the red spots, it's not necessarily good. And it shows that those particular communities are sharing a higher income burden when they're investing in to the nutrition and dietary decisions of their families. From a census tract perspective, because it's not always the best approach to pull data from a zip code perspective, even though many data resources out there are aligned and arrayed by zip code. Census tract is another example by which we pull data. And this one on the right is a percentage of households paying in excess of 50% of monthly household income on housing costs. And this ties, once again, not to the traditional health statistic, but it ties to income security, which plays a critical part in our ability to live a longer life and a higher quality life. On the left side, you see from an environmental quality, climate resilience perspective, the darkest components on the left, it shows non-white or Hispanic Latino population. And then on the right side, you see that it almost perfectly coincides. There's a positive correlation, unfortunately, when we see the pollution burden of California. And this is another example of how our data project has been helpful in visually seeing where many of these disparities and inequities exist here in our state of California. Once again, an example, access to public transportation from a city perspective. And the hotspots in this instance highlights the percentage of residents within a half mile or a major transit stop. So the darker or the redder means that the access to public transit is far more challenging. And just giving you some examples, but also trying to enlighten all of us, including myself, around where many of these social determinant of health challenges and opportunities are. Time series is another way for us to look at data and we think about neighborhood safety and efficacy. Here's another example. And then using the Gini coefficient to understand the distribution of household income relative to the number of households. So if you look as a descriptor, the lower the number is, there's a lower inequality when we think about how income is distributed across various communities. The higher the number is, there's higher inequality, thinking once again about the distribution of household income relative to the number of households. So this is information that we have access to within our office. We share the concern once again, and we often hit those roadblocks around if we want to disaggregate information and dig a little bit more deeply into where many of these social inequalities are that lead to disparities and inequities, it's something that we constantly are up against as well. So I applaud and appreciate the commitment of this committee, and we plan to go upstream in having a more standardized approach and having data more readily available that allows us to address living conditions, institutional inequities, as well as social inequities. So thank you so much for this time.
Thank you very much. We'll move on to Mr. Lee, Executive Director, Cover California.
Senator Hernandez, Senator Bonta, members, great to be with you today. And thank you for hosting this hearing. I think it's a very, very important one. It's timely, given that Cover California just weeks ago wrapped up our second ever open enrollment period. And as you know, addressing health disparities is central to our mission. It's actually written in our mission statement. It was from 3 years ago. And I'll fly by it, but it is important when we think about what we're about. It's not just about getting people in the door and giving them a card, getting them a coverage card. It's getting them access to care. So what I'm going to run through very quickly to have an opportunity for questions is, so 3 elements is update you on the open enrollment period, because a starting point for us is to get people that card. Second, though, is make sure they understand how to use that insurance, is make sure they're educated about health insurance. And finally, to hold our health plans to account, to make sure that they are addressing everyone in our diverse state and our very diverse enrollment. So that's what I'm going to run through very quickly. Okay? So again, our mission statement bakes in specifically that we're about the triple aim, and you heard about this earlier panel, the triple aim, though, with a focus on reduced health disparities. Yes, we want to have better health, better care being delivered, and reduced costs. But if we aren't looking through a lens of health disparities and health equity, we aren't looking at California. So that's been central from day one. So how have we done in our most recent open enrollment period? Well, first, we enrolled a lot more people, about 500,000 people. We now have about 1.4 million Californians enrolled in covered California. I think it's appropriate to be sitting next to representatives from Medi-Cal, DHCS. In this same period, about 800,000, more than 800,000 people newly joined Medi-Cal on top of the 3 million that joined last year. So clearly, when we look at addressing health disparities, Medi-Cal, covered California need to be partners in the incredible expansion we've seen in coverage. When we look at the ethnic mix of who is enrolled, a couple things I'd like to highlight. And this is comparing this year's open enrollment to last year. So this is the second time we've ever done an open enrollment period. And we saw real substantial improvements in a number of areas. First, and in particular, Latinos are 38% of those who are eligible for subsidies in California, and covered California. They represented 37% of those enrolled, very close to the number of the subsidy eligible population, and a substantial improvement from last year when it was about 31%. African Americans are 5% of subsidy eligible. Last year we only enrolled about 3%. We increased that to 4%. Not all the way to 5%, but it's making substantial progress. Last year we did a very good job enrolling Asian Pacific Islanders. This year, it's about 19% of those enrolled compared to about 21% subsidy eligible. We're trying to figure out what's the story there. We continue to do a lot of outreach in those very diverse communities, but it's something we need to learn from and see, was that we did a better job last year? What's that mean? But the overall story here is a couple things. One, we think it's critical to have this data. We know that about a third of the people that sign up don't answer this question. And without having that answer, we can't do the analysis that everything is built on. And we're looking at who doesn't answer and why, how do we boost that response rate so we can use this data as we go forward. How do people get supported to enroll? And this is a really important issue. You heard earlier about the role of navigators. Navigators are very important for helping people enroll, but also to retain their coverage and understand how to use their coverage. That was about 10% of the people that enrolled this last year enrolled through navigators. 43% through certified licensed insurance agents. And we need to understand how did they serve individuals by different ethnic groups, different languages, et cetera. And for all of this data, we're in the process of going through deep analysis to look at, for instance, certified agents, how'd they do with Koreans, how'd they do with Vietnamese, how'd they do compared to navigators for Spanish speakers, et cetera. And so this is an element of where we're in the process of doing the analysis to see how do people get that leg up to understand how to enroll. With our open enrollment period, and I'm going to quickly move on for this, but we had strong enrollment, higher shares of Latino and African Americans, a younger mix, and we found that the support that we had through our service center and major investments there paid off. Expanded both Spanish speaking and a whole range of Asian languages on our service center staff that led to 13% of people signing up through that service center, but also helped people retain their coverage. So that's getting people the card. The next piece, though, well, actually, I have some background on some of the outreach we've done that I'm going to fly through in the interest of time, but we did a lot of things for improving language access, making sure we did outreach with immigration partners, because one of the concerns we've had from last year is the false impression that the information we needed on immigration status and mixed status families might deter people from signing up for coverage, both in Asian communities and in the Latino community. And we had a very good partnership with some of the leading immigration organizations to get the word out. That's not the case. I think that the enrollment we saw was helped by that. We had fact sheets, again, on that same issue, and enrollment support. And it's important to note, when we think about who does enrollment, we have over 1,000 people answering the phone, but there's tens of thousands of people across California doing enrollment. 14,000 insurance agents, 6,000 certified enrollment counselors, county eligibility workers in every county that do enrollment, not just in Medi-Cal, but in Cover California. So that's sort of the opening of the door to get people into coverage. Once they're into coverage, though, we have a number of elements of our doing a welcome to say this is what health insurance is. It's increasingly important as this year, more and more of the people that signed up had never had health insurance before, and you know to this, Dr. Hernandez, it's folks that don't know what a deductible is, don't know what an out-of-pocket is, et cetera. And so helping people understand now that you're enrolled, and it's both our job, but it's also the health plan's job. And so we don't try to create a new booklet, a new 50-page book. It's rather making sure people know the basic terms of what is a premium, what's a copay, and making sure they know where to go to get started, to visit a doctor, to get the free preventive care that's available, to understand what their costs are. And so that's a core element that we have embarked on of using their plan, because again, getting the card's not enough. Third element, though, I'm going to go to is ensuring that consumers get quality care. And we do this in two tracks. One in our certification and selection process of our health plans. So we actually work closely with the health plans we select through a RFP process that asks them what do they do for access and timeliness standards by language. What do they do to provide culturally appropriate care, effective management of chronic conditions. And this is part of our recertification process we're just embarking on for 2016. It's part of the process for selecting plans that are part of our portfolio today. In doing that, we specifically ask our plans, the 10 plans we contract with, what they do in terms of collecting data on sexual orientation, in terms of what they do to collect data to match up services and assess in their enrolled populations, how are they doing? And again, these questions look at disability status, interpreter need, education, sexual orientation. The other big thing I'd flag is that we're now in our second year of providing care to now 1.4 million people. We are embarking on a major data initiative, and one of the themes here is getting data and analyzing it. We will be taking actual claims data from every one of our health plans all pooled together. So one of the questions you heard from Ignatius Bow was some of the things you can do with cloud-based and the question of all payer. We're a purchaser. We're a very active purchaser, like CalPERS, which takes all the data that they have across all of the CalPERS enrollees to say, how is Plan X versus Plan Y doing for serving diabetics? We'll be doing the same thing and have done a competitive RFP process. So we'll be having, not just in the clouds, but in one location, data on all of our members that we can then assess along with race, ethnicity, language, to see not just how our plan's doing relative to diabetics, but are they doing differently for Latino diabetics versus African American? Are they doing differently based on income level of those that are covered by Cover California? So this is a key element that we have going forward. It's going to be an ongoing process. We look forward to working with partners like we have here at this table and you've heard from before, because the issues of having the data, analyzing it, and then using that for accountability for the health plans we're contracting with, for the doctors, medical groups, and hospitals they contract with, I think is part of what our common agenda is. So with that, I appreciate the opportunity to be with you today.
Thank you very much. Move on to David Lown, MD, Chief Medical Officer, Safety Net Institute. Good afternoon.
Thank you, Senator Hernandez, and the other members of the committee for allowing us to speak on this issue that is at the heart of the mission of the organizations that I work for and represent. So, as mentioned, I am the Chief Medical Officer for the California Healthcare Safety Net Institute, which is the performance improvement arm of the California Association of Public Hospitals and Health Systems. These are the county-owned and operated hospitals and clinics throughout the state, as well as the 5 University of California medical centers. So the 3 things I want to touch on today are to talk a little bit about the populations that are served by our member organizations, talk a little bit about the successes and work we've done to date to address disparities, and then lastly, talk a little bit about a next level of work, in particular enhancing standardized, systemic work, which is, echoes a lot of what has been said by other folks here today. So first of all, our members serve just under 3 million patients a year, the majority of whom are, vast majority are under 200% federal poverty level. We provide 40% of all hospital care to the state's uninsured, and over 2/3 of our patients are from communities of color. And with that, additionally, the majority of our members, in order to serve our patients well, participate in the Healthcare Interpreters Network, which provides virtual interpretation services for 16 preference languages throughout California. So a little bit on work we've done to date to address disparities. And I'd say the first I want to touch on is the Low-Income Health Program, also known as the LIP, or LIHP, which allowed California to enroll 700,000 individuals in local coverage programs and prepare them for the smooth transition to Medi-Cal with the expansion of, when Medi-Cal expansion took effect. So our public health systems played a significant role in the implementation of the LIP, and 73% of those 700,000 enrollees were actually in counties with a county-owned and operated health system. The significant challenge for our populations is the lack of continuity of coverage. And the LIP is the first statewide effort that we've engaged in to address continuity and thus begin to address disparities. And the LIP really helped public health systems enroll people into medical homes so they could get the primary care that they really needed. The second initiative is the Delivery System Reform Incentive Program, also known as the DSRIP, not the greatest name, but which is the pay for performance program under the current 1115 Medicaid waiver. The DSRIP provided public health care systems the opportunity to earn financial incentives, financial payments for achieving ambitious milestones that demonstrate system-wide improvements in the public health system care delivery for Medi-Cal and uninsured patients that they serve. I believe you have a brief on the topic that we wrote called Leading the Way. It's also available on our website. So our system is engaged in hundreds of improvement projects under the DSRIP that improve the care for all the patients, underserved populations that they serve. One example of a project was integration of behavioral health, where members engaged in integrating and co-locating behavioral health services into primary care services so patients could get both services, medical and behavioral, at one site, implementing telepsychiatric services also to be able to expand access to mental health. Just one example, there are many, many, many more around care transitions from hospital back to home or primary care, care coordination, complex care management, ED navigators, as we talked about it before, the importance of helping newly covered patients who are high utilizers of the emergency department back into primary care, how to use that system and access the care they needed. Just one example. Other initiatives under the DSRIP, we actually had a couple, I would say, specific disparity reduction focused initiatives. One around enhancing the interpretive services and culturally competent care provided by our systems, in particular expanding the use of virtual interpretive services for our populations. At some sites, this translated to over 8,000 interpreter encounters every month by using this service. So fantastic. The other was around race, ethnicity, and preferred language data. And this included a number of things, but one big point, which I think we haven't touched on today, is actually getting staff buy-in and training of staff to more accurately collect the data in a way that truly reflects what the patients are bringing rather than what staff are perceiving as the responses to these various elements. Also establishing processes for universal capture of this data in a granular and standardized structured manner in the electronic health record and linking that to quality data. One item of note that a number of our members mentioned is that while most are moving towards electronic health records, the electronic health record vendors are only required to have essentially the OMB categories, the standard roll-up categories for race, ethnicity, and language, and do not have the ability to capture the more granular data, which leaves individual organizations with the need to develop that and try and get their electronic health record vendors to do that on an individual basis, which creates a lack of standardization across the field. Some other targeted interventions that our organizations have been involved in outside of the DSRIP and the waiver have been things such as mobile asthma clinics in San Bernardino and in Los Angeles County, Alameda Health Systems implementation of a health equity council, which I think is fantastic, focusing both on the collection of data, but also the importance of health equity. It's from a leadership, from the CEO standpoint, down to frontline staff. Santa Clara County's Black Infant Health Program and their Healthy Lifestyle Clinic in East San Jose, a family-focused childhood obesity initiative, which has had great success. And then Los Angeles' Mama's Neighborhood, also a Black Infant Health Program. And lastly, Natividad Medical Center's Indigenous Interpreting Plus services, providing, well, exactly as it says, Indigenous interpretation for the populations they cover. So lastly, I want to touch on sort of next level of work. So in addition to the various initiatives that I just mentioned, a lot of the work that our organizations have done have been, I'd say, more grassroots driven, based on the clinical and community experience and intuition. And we really want to complement those efforts with a more systematic and data-driven initiatives. So as we've made strides, public health systems have made strides in expanding coverage and improvements in our systems of care. We really want to now also enhance the systematic collection of data. This is obviously a theme across all the folks who have spoken today, including working on staff buy-in and training for a more accurate collection of race, ethnicity, language, sexual orientation, gender identity, and also social determinants of health, including education, housing, social isolation, which are so important and markers of increased risk for disease. Being able to collect that more standardized granular data for improved actionability of the data, implementation of routine system-wide data collection processes, and developing processes to use this data to identify data disparities in services and quality on a routine basis as part of regular reporting efforts. And then, of course, to develop standard processes for developing and implementing interventions to reduce those disparities. Also, we want to build many of these processes into the next Medi-Cal waiver. As Sarah mentioned, their efforts are already ongoing, and we want to try and do that in a much more robust manner. Certainly, having standard system-wide data collection allows greater opportunities to develop structured, targeted interventions for issues that may already be commonly understood to be of importance in and by the community. Lastly, I just want to give just an example of how this has affected patients that I've cared for. A patient of mine several years ago, Mr. S., was a gentleman of Mayan descent from Guatemala who, after a little while, we figured out spoke Quiche. So Quiche is a Mayan dialect, and we didn't have any Quiche interpreters at the time. And we were, although able to work through his Spanish, a little bit of Spanish, to figure out that he had diabetes. But finding the appropriate interpreter services, finding diabetes information in Quiche, and certainly also finding other Quiche-speaking peers was quite challenging. And what we needed to provide the best care for Mr. S. was really routine collection of this granular ethnicity and language data, as well as having the indigenous interpreter services that some of our other members are working on, and access to language concordant health education information. And with these kinds of services routinely in place, we'll certainly be able to better care for the diverse spectrum of people that we have the honor to serve.